The World Health Organization declared the Ebola outbreak a public health emergency of international concern. But that label was never just a medical directive. It was a geopolitical trigger that instantly reshaped trade flows, border policies, and the balance of power in West Africa. Most narratives focus on the virus itself, missing the real story of how a health crisis became a tool for economic coercion. By the end of this analysis, you will understand why accepting aid during a pandemic often means ceding national sovereignty to external auditors, and how the very act of containment can destabilize the economies it claims to protect. When the declaration was made, the immediate reaction from global markets was not to send more doctors, but to close borders. Trade sanctions and travel restrictions were activated automatically, creating a cascade of economic isolation for the affected nations. The 2014 to 2015 epidemic was the largest recorded in history, with over 27,000 cases documented across the region. Yet, the most damaging impact came not from the disease, but from the global response to the declaration. African states faced a stark strategic calculation. They could either maintain their borders and risk total economic paralysis, or they could open their borders to international intervention and accept a loss of control over their own data and policy decisions. Here is the thing that often gets overlooked. The declaration functions less as a public health order and more as a mechanism for shifting power from local health ministries to international aid coalitions. When a country is designated as a public health emergency of international concern, it signals to the world that the local infrastructure is insufficient. This creates a trust deficit that Western donors exploit to bypass local sovereignty. The result is that decision-making power regarding border closures, quarantine protocols, and resource allocation moves from the capital cities of West Africa to the offices of international donors in Geneva and Washington. The complexity of this dynamic becomes clear when you look at the data engineering failures that plagued the outbreak. During the 2014 crisis, there was a distinct lack of standardized digital surveillance networks. Local systems could not produce real-time, verifiable data that met international audit requirements. This inability to provide granular information was not just a technical failure, it was a political vulnerability. Because local engineers could not build systems that satisfied international oversight, external actors stepped in to fill the void. They imposed their own data architecture and monitoring protocols, effectively turning public health containment into a mechanism for external political leverage. Quick resource note. I keep a curated set of Amazon search links in the description for books, gear, and tools relevant to this channel's topics. Some are affiliate links, so I may earn a commission at no extra cost to you. Please consider supporting the channel by using those links if you find something useful. This shift in power dynamics created a trade-off between rapid international intervention and the long-term resilience of local health systems. The strategy of containment through pressure prioritized donor-driven protocols over local adaptive strategies. While this mobilized global attention, it also highlighted a critical knowledge gap in how political urgency translates into effective action on the ground. Simplified models could predict the spread of the virus, but they failed to account for the specific cultural and logistical barriers that made containment difficult. The political declaration alone could not overcome the lack of detailed, culturally attuned data. Consider the uncertainty inherent in epidemiological forecasting. The inability to precisely model the spread of the virus served as a political tool. When local systems could not produce the data needed to verify the situation, it accelerated the imposition of international oversight. Donors used this uncertainty to justify stricter conditionalities on aid. Accepting Western aid often required ceding control over data architecture and border policies. This turned the crisis into a test of sovereignty, where survival depended on accepting terms that eroded national autonomy. The evidence suggests that the declaration successfully mobilized resources, but it did so by forcing local engineers to build systems that satisfied international audit requirements rather than local operational needs. The strategic calculation for African states involved a fundamental choice between sovereignty and survival. On one side was the risk of global market isolation, which could cripple an economy in days. On the other was the loss of control over their own health infrastructure and policy decisions. The declaration made this choice binary. Once the status was assigned, the path of least resistance was to accept the aid, even if it meant surrendering authority. This created a dependency on external auditors that persisted long after the immediate threat of the virus had receded. The trust deficit was not just about the virus, it was about the inability of local systems to communicate their own reality to the global community. This dynamic reveals a critical failure mode in the global health architecture. The absence of a unified, decentralized data layer allows the international concern status to be weaponized for economic coercion. When a country cannot prove its own stability through standardized metrics, it becomes subject to external mandates. The declaration effectively bypassed local health ministries, shifting the locus of control to international coalitions. This means that the response to a health crisis is often driven by the incentives of the donors rather than the needs of the affected population. The result is a system where containment is prioritized over resilience, and where the political utility of the crisis outweighs the medical necessity of the response. The ultimate lesson here is that the declaration of a public health emergency of international concern is not a neutral medical act. It is a geopolitical instrument that triggers immediate shifts in power and resource allocation. The 2014 to 2015 outbreak demonstrated that the primary efficacy of the declaration lay in forcing a strategic realignment of resources rather than just containing the virus. While the global community mobilized to stop the spread of Ebola, the cost was a significant erosion of local sovereignty and a reinforcement of the dependency of African states on Western aid. The data shows that initial surveillance failures and parameter unidentifiability in disease modeling hindered the precise targeting of interventions, leaving a gap that was filled by external actors seeking to impose their own solutions. In the end, the declaration revealed that the architecture of global health is deeply political. The tools designed to protect populations can also be used to exert control over them. The trade-off between rapid international intervention and long-term local resilience remains a central tension in how the world responds to future crises. Understanding this dynamic is essential for anyone trying to make sense of why states behave the way they do when faced with a global emergency. The choice is never just about health. It is about power, sovereignty, and the strategic calculations that define international relations. Thanks for watching all the way to the end. I am a one-person team working hard to make each video better than the last. Subscribe if you found value. It is the best way to show support. Drop a comment with your biggest takeaway. See you in the next video.